All right, thank you guys for having me. I'm Joe Sanchoa. I'm a head and neck surgical oncologist and reconstructive surgeon over at the University of California in Irvine. Such a great conference to be at. This is actually, we go to scientific conferences all the time where we interact with other surgeons and the oncologists. This is the first time I've ever been at a patient and provider conference, and it's so valuable. It's amazing that more of these don't exist. And we hear the comments in the group, and everyone is hungry for support and a support network, and something like this is so important for patients and for providers to hear what patients are going through. So thank you for having me. Our topic here is shared decision-making. And shared decision-making describes this kind of collaborative process that physicians and providers go through with their patients. And it's to try and come up with an understanding and a way to make decisions together using the expertise of the provider and taking into account the values and preferences of the patient. And so really it's central to a conference like this. Really the question is, how do we understand what patients want and use the knowledge that the providers have to make the right decisions? And it's different, not just by disease process, but it's different by individual, and that's so important to recognize. There's a lot of different models about shared decision-making, but ultimately it comes down to the provider being able to define the problem. Why is head and neck cancer important? To find the solutions to that. We have radiation, we have surgery, we have chemotherapy, we have immunotherapy, and then talk about the risks, benefits, pros, cons of each of them, but ultimately to also take into account what does the patient want, what are the patient's values, because none of that knowledge means anything if we don't know how it affects that patient that's sitting in front of you. So shared decision-making necessarily takes into account all of that. And it also takes into account how much the patients want to understand. All of you are here today, so we know all of you want to understand more about the disease and the treatments that you're going through. But some patients come and they really don't want to know. They just want to be told what to do. And it's important for the providers to recognize that. So in this session, we're fortunate to have a diverse panel. We have a physician, a nurse practitioner, another physician who's the medical director of a palliative care program, and a cancer survivor. Together, they'll explore how collaborative conversations between patients, caregivers, and providers can lead to more personalized and effective care. So we can get started by welcoming each panel member. Julia Porter, she's our first speaker. She's a survivor. She's a speech pathologist at Indiana University Health, and she's also a survivor of adenoid cystic carcinoma. Julia is going to share with us her personal cancer journey, how she navigated fear and anxiety, and the strategies that she uses to overcome these challenges while helping others do the same. She's also going to talk about why shared decision-making is so important to the patient, loved ones, and the care team. Next, we'll have Dr. El Megami. She's the chief of the Division of Head and Neck Surgery at City of Hope, which is another National Cancer Institute designated comprehensive cancer center. Her team offers patients the latest in evidence-based care, access to modern technologies, supportive care medicine, and leading-edge research. And she has a fierce commitment to outstanding personalized care. Dr. Jessica Kaltman will speak next. She's the medical director of outpatient palliative care, and she's an assistant professor at UCLA. She provides specialized care for individuals living with serious illness, focusing on complex symptom management and offering compassionate support to patients and their families. Her work is driven by a commitment to advancing innovative outpatient palliative care models that reduce healthcare disparities, improve quality of care, and promote emotional well-being at the end of life. And last but not least, Beverly Garber will talk. She's a doctorally prepared adult nurse practitioner who specializes in otolaryngology, specifically head and neck surgery at UC Davis Health. She provides comprehensive care for head and neck cancer patients and their families, emphasizing a patient-centered, team-based approach to treatment, surveillance, and survivorship. She's also a certified tobacco treatment specialist, supporting patients in tobacco cessation efforts. Her research interests focus on depression screening among head and neck cancer patients, as well as quality improvement strategies to improve timely, guideline-adherent care. So first up, we'll welcome Julia Porter.
Okay. So yes, my name is Julia, and that was me in the photo back there at the beginning slide. I realize I need one of those poll things so you guys can vote on the blonde versus brunette. But anyways, I am the survivor panelist, but I'm also a speech pathologist, and while I can only take one of those hats off, there's still definitely going to be a bit of an SLP layer here. But I'm from southwest of Indianapolis, born and raised. I work north of Indianapolis at Indiana University Health. And being in LA brings back some really good memories for me. In fact, the last time I was here was 9 years ago, when my husband and I landed at LAX to start our honeymoon journey up the coast of California. We rented a convertible. We thought we were really cool and original until we saw like 1,000 other couples doing the exact same thing. But it did hit me when we landed this time around that was really my last, I think the last trip I took before my cancer diagnosis. Because a few months after getting home, I started to experience these, again, that's kind of the theme here, some weird symptoms. First I thought maybe it was just the changing seasons. Then I thought maybe I had a cold. Then suddenly it was spring and maybe I have allergies. But eventually it became something that I couldn't ignore any longer. And that thing ended up being stage 4 adenoid cystic carcinoma of the sinuses and the skull base, and then really kind of hit the ground running. Anytime you hear that, the C word, I think as it was called earlier, suddenly a lot of decisions need to be made, a lot of conversations need to be had. You're kind of told where to be and when to be there and who you're going to see and what day, but I have work and I have this. Nope, you're going to go see this person at this time. I was fortunate enough to be able to have A, treatment options, and B, options or choices of where to go to pursue those treatment options. But however, as Wade alluded to earlier, sometimes having choices can kind of muddy the waters a little bit. I mean, these stakes are so high, like this is literally your life, that you're choosing, where and who to put your life in their hands. But through it all, I really was an active participant in those decisions and those discussions about my care plan. And this really helped me make informed decisions about where to go and what to do. And so, what does it mean to be a participant in person-centered care? This is care that's delivered in a setting, in a manner that's responsive to individuals and their goals, their values, their preferences. It's in a system that supports good communication and really ultimately should empower people to be able to make effective care plans with their providers together. And so, again, my providers, kind of regardless of their specialty or institution, were able to kind of present that information to me in an unbiased way and in a way that I ultimately understood. And so many of you in this room are survivors, and so maybe these conversations aren't necessarily about how to treat your cancer, but how to deal with the things that you're living with as a result of your cancer treatment. Again, for me, a lot of that was and still is, fear of cancer coming back, trying to kind of move on to that after treatment life with hopefully the rest of my life ahead of me. How do I approach those decades of decision making about family and things like that? Cancer already kind of took me for this ride. Now I have all this to deal with. So how do we take some of that autonomy back? We can name what's important to us, to ourselves. We can name that to our care team, to our caregivers, our family. We're all thankful to our oncologists for saving our lives, but telling them what you're dealing with as a result of what they did to you to treat that cancer is okay. It's not going to make you any less grateful. They're not going to think any different of you. Tell them, what you're still dealing with. Report those things and how it's affecting your day-to-day life so that you can get connected to the things that you need to adequately treat it. For example, your speech pathologist knows that swallowing is important to you. They know how swallowing is important in their own lives, but maybe adding some context to that in your visits of, I need to be able to eat at the dinner table with my family. Our Sunday dinners are sacred to us, and this is why I need to be a part of it. How can you help me be a part of that interaction that's so important to my life? And again, some other options up there. Other tools I like, your providers are obligated to present information to you in a way that you understand. If you don't understand, please explain this another way. I don't think I'm following you. Please go over that again. That's within your right as that patient being an active participant in your care plan. And of course, I do want to say, if you're going to record conversations, if you can't bring that extra set of eyes, ears, just make sure you ask permission first. Some institutions might have rules about that. And I think it's also important to note that it's okay not to advocate every time. It can get really tiring to be in that role. And because I can't take my speech pathologist hat off, I do also know that maybe many on the call virtually or here in this room might have had some really personal conversations with their speech pathologists about how to deal with or manage this dysphagia that they're living with. And so I think some of these questions are important to ask. Are there other things or procedures, therapies, et cetera, that could help me reach my goal of sitting at the dinner table with my family and enjoying food? What specific factors have you taken in consideration when making this recommendation? We shouldn't make diet recommendations lightly. Management of aspiration, management of swallowing challenges after head and neck cancer, or swallowing challenges in general, is not a one-size-fits-all approach. So what does your provider know about you, and how are they taking that into consideration when determining or making the care plan with you? So again, can't take that hat off, but I will leave you with a quote from someone that I found, make sure I'm on the right slide here, okay, who I found early in that Googling phase of diagnosis, which Google was like super depressing at that time. Stage 4, cool, that's awesome. Oh, it's solid type, that's got a negative prognosis with it, cool, okay, that's what I have. Oh, I have Notch1 mutation, also not cool. But in all of that, I found someone named Gabe, and she was actually dealing, I think, with her second bout of adenoid cystic around when I was diagnosed. And finding her just was really inspiring to me, because I was like, here's somebody who's living with recurrent adenoid cystic carcinoma, who's just really living out loud with this. Cancer really is the most hostile of takeovers. And I think that, this quote, being brave, it really means not giving up on those things that make you feel alive. And that can be really vulnerable to admit, this is what I really want to do with the time that I have. And that can be really scary. And so when you do that, you're brave. And that to me is what bravery means, I guess. So anyways, thank you.
Greetings. Nice to be here. Let me get myself situated. I don't have my, I can use a little assistance here. I can't imagine my life one day without speech and language pathology on my team. Everything I do as a head and neck surgeon is really based on them being able to partner with me and help my patients recover speech and swallowing function and become whole again. I want to thank the meeting organizers, the Head and Neck Cancer Alliance, for this opportunity to speak to the very important issue of shared decision-making, which is really paramount for success in oncology. I am here on behalf of my entire division of head and neck surgery at City of Hope, and it's an absolute pleasure for me to be here. Thank you for the invitation. Julia, you are a speech and language pathologist. My hat off to you, but thank you for being the patient champion on this panel and bringing your perspective to this. Co-panelists, really nice to meet you and be in your presence. So these beautiful people that you see here are a number of my patients who I've had the privilege to care for over the years. They are multifaceted, beautiful people with dreams and aspirations, and family and loved ones who love them and live for them and care for them. As you can see, head and neck cancer comes in different forms at different ages, different genders, and people from all walks of life can be afflicted by this condition. Just look at this room. Just all of you are beautiful and very colorful, and this is really a wonderful session, being able to share, my perspective from a provider, and it's just a wonderful experience to be here with you. As a head and neck cancer surgeon, I learned very early on in my career that good decisions are not made alone by the MD team. And, the best treatment plans are those that are formulated together with patients and their loved ones in a shared decision-making process. For sure, curing the disease when possible or alleviating pain and suffering are our top priorities as cancer providers. Nevertheless, we must tune in. We have to attend to each patient's individual situation, values, and priorities to achieve best results. Sir William Osler said it the best. This is a famous quote from him. He's a famous Canadian doctor over a century ago. At the time of his death, he was the most famous physician on the planet, not because of some huge groundbreaking technique or discovery, but because of his humanity and because of the style of doctoring that he brought to the patient's bedside. So shared decision-making is absolute key for successful doctoring, especially in the field of oncology. It is important that we help patients make informed decisions that align with their values and with their life priorities. And, if you're an older patient, you might prioritize autonomy, independence, and quality of life over duration of life. But if a younger patient with a young family at home, you're going to prioritize life duration over all else because you want to be there to nurture your children and see them to grow into adulthood. Treatment of head and neck cancers can be complex, and deciding between them can be quite difficult and a daunting task for patients. It is important that we be honest and open in our discussions with patients, give them the time and grace they need to process the information. We have to paint a fair perspective on different treatment options that are available for patients and take the time to review pros and cons of varied treatments. It is important that we welcome and engage caretakers and loved ones into the conversation because they bring a whole different perspective to the meeting. The interactions that the physicians have with patients is very intense, and they happen in these very condensed short periods of time. The perspective that the caretaker, the family member, brings into this heated discussion is extremely invaluable because otherwise we can lose sight of some of the important things that are important to each individual, unique patient. Important facets of a patient can be easily overlooked in our fast-paced, demanding lives as oncology providers. We need to remind ourselves to be patient with our patients and to be curious, to dial into specific patient needs and nuances that ultimately influence our success in the patient treatment experience and final outcomes. What is best treatment for one patient may not be available, appropriate, or acceptable for another patient, so things to keep in mind. So I want to share an example of shared decision-making that happened in my recent practice. I chose this patient in particular because it's a common scenario in modern head and neck oncology practice in the United States. And despite the many recent advancements in the treatment of this particular disease that I'm about to discuss, the best standards of care are still widely debated, and there is no one best standard. The title says case study, which is really trade jargon, formal and impersonal. In reality, this is a true story of a human being, someone's loved one who walked into my office one day with his entire world turned upside down on his head, with a new cancer diagnosis and all the uncertainties and devastation that goes along with the C word. On any other day, this could be any of us in this room, and this particular human happened to be a man that was happily married to a loving wife, gainfully employed as an engineer who had never even smoked a cigarette in his entire life. So, I'm sorry, I'm going to go back. He presented to his primary care doctor with a left neck mass. And his primary care doctor ordered a CT image and referred him to an ENT. Long and the short of it is he got diagnosed with HPV-mediated tonsil cancer, which is a common diagnosis in our clinics. As is usually the case, PET scan is done to kind of get a sense of disease burden and distribution in the body. So one was ordered for him at our cancer center. Unfortunately, he had the incidental finding of another cancer on top of the tonsil cancer at the same time. So the PET scan showed a kidney cancer that he had, and the urologist said he's going to need to have his kidney removed as well. So this poor guy is having parallel discussions with the head and neck team and the urologic oncology team, trying to figure out what to do and how to balance the different treatments of the two diseases, in parallel for himself. I, as a head and neck provider, took him to head and neck tumor board, and after reviewing his data, we decided that, well, he has a surgery option, but he also has, chemoradiation as an alternative option. And so it was upon us to discuss the pros and cons of the different approaches to management to help him make an educated decision that would be best decision for him and for his family and life circumstances. So when I was a resident at this fine institution that's hosting this wonderful meeting today so many years ago, which brought nostalgia back of the younger version of me when I was running around campus over here, on the left, you see what was surgical, possibility for tonsil cancer back then. To get to a tonsil cancer as a surgeon, I would have had to place incision on the face. I would have had to break the jawbone. I would have had to, get back to the back of the throat to cut the tonsil out. And then a reconstructive surgeon would have had to partner with me to transfer tissue from one part of the body to the back of the throat to do the reconstruction. And then a very intensive program of rehabilitation would be necessary to try to restore swallowing function for the patient. So then came along recently robotic technology and robotic contributions to science and medicine. And there were technical evolutions in the treatment of tonsil cancer, including use of robotic technology for management of tonsil cancer, which now allows operating through the orifice of an open mouth without having to place incisions and scars on the face, without having to break the jaw open. So in a matter of 2 hours, you can potentially go in with robotic instrumentation, snake-like cameras, snake-like instrumentations for surgery, and cut the tumor out and potentially render a cure. So surgery became attractive again for management of tonsil cancer, whereas before robotics, what was happening, patients were being treated with radiation or chemoradiation therapy, trying to avoid the facial scars and the disfigurement and potential swallowing difficulties associated with radical open surgery. So we offered the patient robotic surgery at City of Hope, but we also discussed chemoradiation as an alternative option. There were pros and cons for the different approaches for management. Favoring robotic surgery was the realistic possibility of having lesser radiation therapy after removing the tonsil tumor with the robotic surgery device. But more importantly, there was an option, there was a true possibility of avoiding chemotherapy altogether in this patient, especially given the fact that he had one kidney and we had to do everything we needed to do to preserve the one kidney going forward because of the nephrectomy he needed for the other cancer that was diagnosed. But, in the second or third visit, what came along was the fact that he had sleep apnea, and he was using a CPAP mask during sleep every night. And I'm sure there are people in this audience that have sleep apnea. It's a common condition, but it's a situation where the patients just don't have enough air when they sleep, and they have to wear a positive pressure mask over the nose to keep the airway open so they can have good oxygenation as they sleep and get a restful night sleep. But the problem is, after robot surgery, you have a raw opening and a wound in the back of your throat, and you cannot have positive pressure appliance on your airway. So the sleep apnea was a relative contraindication, or at least a relative concern for us surgeons for going forward with robotic surgery. So to offset that concern, he went and met another robotic surgeon in the community for an independent discussion separate from me. He also met with the radiation oncologist at the institution to discuss radiation as a treatment approach and chemoradiation therapy and what that might look like and what to expect after that. So just to cut to the chase, we had 4 separate pre-op discussions with this patient to discuss varied options, and thankfully his wife was there every time and extremely supportive and very, very, very involved in the discussions and helped guide, his ultimate decision to go forward with robotic surgery. So thankfully, he had the robotic surgery. Surgery went well. He didn't have any issues with his airway, no bleeding. He didn't need to, be trached or have intubation or any other intervention for airway distress. And we were able to send him home on a soft modified diet as is usual after his robot surgery. His pathology was favorable in that his margins were negative. However, because he had one metastatic lymph node, he still required addition of radiation therapy to the surgical program. But, thankfully, we could give him lesser dose of radiation therapy. Lesser dose means less toxicity, less dry mouth, not like what's happening with me right now. I'm having a hard time even finishing my sentence. But, we were able to do lesser radiation. We didn't need to do chemotherapy. So yes, hooray, objective met. So he went on to get his nephrectomy. His kidney cancer was removed. That operation was successful, thankfully. And, 6 weeks later, he was able to start his radiation program, on schedule. He completed his radiation. And with my amazing speech and language pathologist, he was able to rehab and recover, and he's eating a regular diet and doing well and back to life. So I will end this story on a positive note and close with one of my favorite all-time quotes, as it captures the very heart of shared decision-making, and it just so happens that it was spoken by one of the founding fathers of City of Hope. There is no profit in curing the body if in the process we destroy the soul. The quote reminds us that true healing is not just about treating the disease, but about honoring the whole person, their voice, their values, their humanity. It's about helping people live their best versions of life, to live their best lives. It has been an honor for me to be an oncology provider. Thank you for giving me the opportunity and privilege, and thank you for your attention.
Thank you. Once again, I'd like to thank the organizers as well. I'm really honored to be part of this panel today. I'm Jessica Kaltman. I'm a palliative care physician, which I know as a palliative care physician often sounds like a scary term to so many people that get cancer. We're really a specialty that helps patients walk through their cancer treatments no matter what the outcome might be. We help manage your symptoms. We help be a sounding board when the big medical decisions feel really, really overwhelming. And we also want to just make sure that you're feeling emotionally supported. And if religion and spirituality is important to you, making sure that's well supported too. And so a big part of what we do on a daily basis on every visit with our patient is a lot of shared decision making. So trying to understand what's important to them, what they value, and how that might really relate to their medical decisions, and how we can communicate that to the rest of their amazing medical team. So I'm going to talk a little bit about two of my patients today. One topic that comes up a lot is shared decision-making in symptom management. There are so many drugs. There are so many options. And sometimes the drugs we're recommending for symptom management don't match with your lifestyle. There's concerns about driving your children to school. There's concerns about going to work every day. And so oftentimes we do need to sit down and really talk about what might be the best medication or non-pharmacologic intervention that might help manage your symptom while also letting you go about your day-to-day life. So my 58-year-old patient with base of tongue involvement and pulmonary disease of a squamous cell, married, he's got one child, a wonderful writer, came to me after he had had a recurrence with assistance with symptom management. He had neuropathy caused by chemo, joint pains, dizziness, my favorite combination of dry mouth, but also maybe some excess secretions at times, and a significant amount of post-traumatic stress from his previous treatments, thinking about going into treatment again, what it was going to be like, what life was going to be like. And it also was partnered with some depression. So when we talked to him about his various symptoms, he was someone that really, really wants to minimize pharmacologic interventions. So even a Tylenol makes him want to run in the opposite direction, which as a palliative care provider, sometimes you're just sitting there being like, please take the Tylenol. I can see you're so uncomfortable. Please take it. But we also want to respect our patients' choices that sometimes, they don't want to take any drugs to manage their symptoms. So we spent a lot of time talking through things outside of medications that could help. For dry mouth, I have some patients that swear by chewing gum, and that really helps them get through the day. I have a patient I love to talk to nowadays. He can tell me his favorite brand of gum, his favorite flavors, and it really helps him, get through his workday and lets him enjoy food a little bit more. Biotin, which I'm sure a lot of you are familiar with, is one of my favorite choices. Neuropathic pain can be really complicated. A lot of patients don't want to take the neuropathic drugs. They have a lot of side effects. Sometimes their efficacy is not great. And so really sitting down and trying to understand from the patient perspective what their day-to-day life is like and what they need to get done. And then me using my toolbox, I always like to say I have a toolkit, and offering things from that toolkit that matches what they need to get through their day. And it's really, I find it a true partnership in managing symptoms with my patients, talking them through. I always get the inevitable question like, hey, Dr. Kaltman, what about marijuana? Can I use that? Is that okay? And walking through that. And I really enjoy talking with my older patients who have never had a drug in their life, whose grandchildren are like, you've got to try some cannabis, Grandma. You have to do it. But it's, that's just to say there's so many choices and so many ways to manage symptoms. Sometimes we have to be creative. Sometimes we have to gather all our colleagues, our speech therapists, our physical therapists, our nutritionists, our oncology colleagues, radiation oncologists. I can name you guys have such a wonderful team that takes care of you and working together to think maybe outside the box sometimes. Another case I want to talk to you about is some challenges sometimes with shared decision making. Because that comes up too, and trying to understand from the patient's perspective, sometimes they want doctors just to tell them what to do. And sometimes we're spending so much trying to make that shared decision that sometimes it's actually causing a lot of distress on the patient and their family because they are like, I just need that guidance. Outside of medicine, I talk to friends who have had loved ones go through treatment, and they're sitting and they tell me all the time, because sometimes they forget what I do because they knew me before I became a doctor, and they say, I was sitting with my dad's advance directive, and I was like, I don't know what to do. And I always say, well, you should have called me. They're like, I know, I forgot. That's what you do. But really, the caregiver, that decision maker, there's a lot of responsibility on them to sit down and try and interpret these legal advance directives that exist. What decisions do I make that my loved one, wants? And that becomes really hard. Sometimes I just wish the doctor would tell me what to do because I don't know what to do. I had a really wonderful patient who had a very, very aggressive form of left lateral tongue adenocarcinoma. She had resections, multiple treatments. She was married with one child. And she initially came to me for symptom-managed support and some early advanced care planning. She was very fortunate that she had access to multiple institutions, multiple specialists, family friends that were in the medical field. But it almost became too much. There were too many cooks in the kitchen trying to guide her care, trying to give her advice. And I think ultimately it led to a lot of overwhelming decisions, a poor coordination of care at times. And what was really hard is that she developed really extensive facial edema after trach placement and eventually lost her ability to fully speak, also lost her vision due to the edema, and so was really stuck in a very isolated place. And I think one of the challenges we faced is we tried really hard while she could communicate to talk a little bit about what her medical wishes are, what was really, really important to her, so that we could involve her and her family in shared decision-making as much as possible. But I think because there were so many cooks and so many players, it just became more and more challenging and resulted in a lot of conflicting opinions, conflicting treatment plans, and some poor coordination care. And I think what really happened was a loss of the patient autonomy. And that's to say shared decision-making is really important, but it's also really important when there's not enough guidance, there's too many people involved, there can be a danger in it. And so for us, always maintaining the patient at the focus and remembering them and what's important to them can really help us guide their care. And just to end with a quote from one of my favorite authors, Barbara Kingsolver, "Hope is a renewable option. If you run out of it at the end of the day, you get to start over in the morning." And I think that's true for all of us in this room, whether we're dealing with a serious illness or not. I know when I have a bad day and I go to sleep and I wake up in the morning, I like to say it's a new day, new hope. Maybe my kids won't hit each other today. Maybe there'll be something like that, but it's always nice to wake up in the morning and remember it's a new day. So thank you very much.
Thank you all for being here and sharing all of your wonderful stories and expertise. I'm Beverly Garber, I'm a nurse practitioner. I'm very happy to share my experience in shared decision-making. I first want to just mention that I believe shared decision-making as a negotiation between the patient and the caregiver and the clinician. Unfortunately, a lot of the times it's not aligned and the goals are not equal and may be in competition with each other. So I think it's very important to acknowledge that, and in the clinicians in the room to experience that themselves and think back to their time with patients and how they can provide the care we need to provide as clinicians, but also incorporating their individual goals. The case I'm going to present today is really just an experience the patient presented me with. I just finished healing from a huge surgery. I don't feel ready to start radiation yet. I just want to wait. So clearly, this patient's goal is to rest, is to recover. The time they need to feel better, to feel that their symptoms have improved. And that's hugely important. But as the clinician, I know the time is counting down. This patient needs radiation. And we have evidence-based practice guidelines that direct clinicians to improve outcomes by helping our patients achieve their radiation therapy within a timely manner. So how do we balance that? How do we as clinicians educate patients and their caregivers about the importance of these guidelines while also honoring and respecting their need to rest? There's no answer to this outside of acknowledgement and accepting where the patient is and meeting them there that day. So a lot of times a shared decision is that negotiation, understanding the patient, where they come from, what they need, acknowledging that, but then presenting them from the clinician standpoint on the evidence. I understand this is a very challenging time for you. You need time to rest. We want you to know that your best outcomes will be if we get your radiation started within a timely manner. How best can I support you to achieve that goal? Again, there's no right answer. The patient and the caregiver will often help us in making that shared decision. The next case is someone I just encountered a few weeks ago. This individual just finished their radiation. I'm so overwhelmed. I don't even know what I'm here for today. That was the first thing he said to me when I just walked in the room. And as a nurse practitioner in the ENT department, my goal is to help the patient start their surveillance period, start the post-treatment planning, talk to them about survivorship and their surveillance schedule and their post-treatment imaging. Clearly, that wasn't the conversation we were going to have that day. This patient needed to talk. Being overwhelmed will paralyze you. That information that's given to you as a clinician, you may not be able to absorb. So as a shared decision, the clinician should stop and listen and hear what the patient is needing at that moment. And that's what we did. We just talked. That patient just needed to talk. And that was the shared decision of that visit. And we met again, and then we're able to have another conversation with my goals to help them understand how often we need to see him, when his timing for his treatment imaging might be, and start talking about survivorship. So in summary, and I wanted to keep this brief because I want to make sure we have time for questions, I feel as though the shared decision-making is really a scale. It's never going to be balanced, and oftentimes our goals do not align. But like Julia said so astutely, tell us, as clinicians, we need to know your goals and what you need at that moment, and together we can make that shared decision and negotiate whether it's timely treatment, what you need in that moment, how we can support you. We don't know what you don't tell us, and again, the guidelines will help us give you the best outcomes and survival, but it takes a shared decision to help you live your best life, and that quality of life is very, very important to us as well. My quote is nothing profound, but I've heard a lot today, and we've all heard this, the new normal. I don't believe in that. It is new, but it's not normal. Tell us, speak up, advocate for yourself. There may not be something we can do, but it's important that we share that discussion and those decisions and support you the best way we can. Thank you.
Thank you to all the panelists. What a great, diverse group of perspectives that those came from. I would imagine that there's something in each of those talks that resonated with every single person in this room, both patients and providers. Before we move to the Q&A session, we're going to take a quick poll. So if you take out your phone, laptop, tablet, join our live survey using one of the following options. And then for those asking questions virtually, please remember to put it in the Q&A and not in the chat, and that way it'll come across here. And for the questions that are being asked in person, I'm going to repeat them just so that everyone online can hear them as well.
There we go. Right now? Sure. Okay. When it comes to shared decision making, what's the biggest hurdle? And we have to go back.
I don't know how to get back there.
It disappeared.
Yeah, it looked like it was balancing the risks and quality of life.
And so here we are, and it looks like in the lead is balancing risk versus quality of life. Second, understanding of treatment options. And then we have lack of coordinated communication. And then time pressure to make decisions. And then finally, patients feeling unheard.
Thank you. Are there any questions here or comments? We do have one that came through the Q&A, and I'll ask this to the panelists. How does the medical team advocate for an integrated approach? And are you asking about psychological support and strength in your visits?
I'll mention at every visit we do address mental health through a questionnaire with the hope of identifying patients who may be at risk at any point of their treatment journey. But the caveat to that is then access to the support has always been a challenge. So knowing your community resources, asking for a supportive oncology, if your institution has one, can help identify opportunities for mental health or distress. But I will also say sometimes the biggest challenge is there's resources for the patient and less resources for the caregiver. So that's where meetings like this and advocacy with the Alliance can really help connect you with those opportunities as well.
While others are getting their questions together, don't all jump in at once. I'll ask a question. Tony Askander from Toronto. I'm a surgeon. The question for the panel is about shared decision-making tools. There's this whole area of research of people using either an app or a video or some other type of interactive tool to help folks make decisions about treatments. I'm wondering if anybody's used them or kind of some of the pros and cons of using them as opposed to just having that personal one-on-one conversation with the patient and their caregiver.
Hi, Tony. I don't personally have any experience using the app, but I know that myself and I'm sure a lot of people in oncology, we just make sure that the patient gets as much access to the team as necessary. So if they need to come back for further discussion, even if it's telehealth appointments, telemedicine, it's hard for them to come in person, but they have questions. And so we're kind of very liberal, allowing for those conversations to happen. And we actually invite them to invite whoever is important in their lives to help, them make up their mind to participate in that. If they don't speak English, we make sure we have translators available so that they can hear it through their own language to be able to process it sort of more directly one-on-one. So I think that's extremely important. So we just meet the patients and we give them as much time as they need.
I love that. Dr. Lin and I noticed that you've met with the patient 4 times in that case, and so that was a great example of that.
I was going to say, I have not used any apps in my own personal practice, but I do think just in the era of like AI and ChatGPT and everything like that, that really is going to play an interesting role, I think, in terms of now it's like the new Google. I think back probably when I was diagnosed, I probably would have gone to ChatGPT first and maybe would not have found, other resources like Brave Like Gabe and things like that. But I do think we're really going to have to wrestle with some of the information that comes through these big language models and things like that, and learn how to harness it in a way. I remember I had a visit with someone who was in their 80s, and it was my first time meeting them, and I don't think they knew why they were coming to see me, but they handed me something they'd printed off clearly from ChatGPT that was, "What is a speech pathologist?" And so that was kind of a wow, like this technology is becoming accessible to a lot of people. So.
Yeah, those are great answers. Dr. Megami brings up a good point. There's language barriers that we often have to overcome as well in trying to figure out what the patient understands and wants. And sometimes there's cultural barriers, and there's even some cultures where the caregiver doesn't want the patient to know even their diagnosis or what we're going to do to them. And so those present ethical challenges. But I'm sure all the providers in this room have come across that situation. And everything really has to be individualized.
Yeah. I just want to make a comment. Having gone through 3 separate cancer experiences, not ever do I recall doctors or the treatment staff mentioning the psychological well-being of the patient. I've gone through the aftermath of the treatment where the patient obviously has many psychological issues in the treatment, the side effects, and the ongoing treatment. So I commend you for bringing this issue up because it's real. Thank you.
Thank you.
I think to that, so personally as I was going through treatment, and every week, if many of you in this room are probably familiar with the distress thermometer tool, every week I got that thermometer to fill out, and every week I would circle 0 just because I was my radiation oncologist said I was very stoic. I kind of held a lot in, and at the end of treatment or a few weeks after, he asked how I was doing, and I was like, I'm fine, which of course is the opposite of what I said here of tell your providers how you're doing. But, and it really just showed how much he knew me as a person, as a patient, that he was like, I'm going to send you to our psychologist. And without, I was very thankful for that, but I didn't tell him that. He got that information from reading me, my vibe or my aura, is that what they say now? So so even with some of those tools out there, like you have to be able to like zoom out and like see your patient too.
Just to piggyback on Julia's comment, I think there's a very large underreporting of distress, mental health, depression, anxiety. And again, we don't know what we aren't told, but as clinicians, I think we are becoming more aware and reading the room, understanding when we meet with you at the beginning of your treatment journey, understanding those dynamics, and then seeing that evolve and picking up on some of those communication barriers, frustrations, body language, tone of voice. I mean, there are many, many things that are non-communicated that we should be paying attention to. So I'm very hopeful that that's happening more and more. There's a lot more research and education and awareness about the need for mental health within this, as I think we've learned after treatment sometimes is the hardest. During, you're in go mode, and it's when everything is done and the visits have stretched out that you may feel lost and unsupported, and that's maybe the time we need it the most to be there for you.
And I agree, and I think also to say that caregivers can sometimes get lost in the process. There's not a lot of resources oftentimes, I feel like, for caregivers, and their stress and their psychological well-being can really take a toll as they support someone through this process. And so if you are a caregiver, it is so important for you to take care of yourself, including, both your physical but also your mental health. And so it is okay as a caregiver to take a break sometimes and take care of yourself. And I agree that I often see it's really when the treatment ends and you're waiting and you've put so much time and energy into getting through that treatment, it then becomes, what do I do now? And I think that's where psychological support is really helpful.
And just one more response to that comment. I feel like all of us spend, 10 to 15 years of our lives studying to be specialized in one thing. And for me, it's doing surgery and doing reconstructive surgery and cancer surgery. And we don't spend time learning about the psychological and the mental and the physical or the emotional impact on patients. And so that's on-the-job learning. And some of us are better at it than others. But I do think one thing that I've seen in going to these meetings is anyone who takes care of head and neck cancer, I feel like it's a special group of people because there's been so much on-the-job learning about the psychological, mental, and emotional impact to patients because it's such a critical part of how everyone feels who they are.
I just wanted to mention that one discipline that hasn't been brought up yet, everybody who's gone through cancer treatment appreciates how many people are involved in your care, and I understand that's extremely overwhelming at times. But one discipline that's fairly new to the cancer care team is a navigator. Some navigators are non-clinical, but some are clinical. I work as a clinical navigator, and one of the things, the primary role of a clinical or even non-clinical navigator is to address barriers to care and to connect patients to resources. So, if you've already gone through cancer treatment and it's been a few years, you may or may not have had a navigator on your team, but if you're still in active treatment or in the, early survivorship, I would say reach out to your care team and see if you have a navigator on your team, because that person is an advocate between your needs and the medical system. So I just wanted to bring some awareness to that person's role as well. And most cancer centers now have some type of navigator available to patients.
All right, and I think with that, we are at time. We have one more.
I was just going to say that was a perfect segue. I'm the patient resource navigator for the Alliance. So if you don't have a navigator or you are looking for a navigator associated with your setting, please reach out to me as well. I'm very happy to connect you to those resources or find the answer if I don't know it right away. But I did want to mention some of our support that we do offer to anyone who, if you are not familiar with some of our programs, we have quite a few programs that can help you with some of the psychological support as well as some of the interpersonal support. So we do have a peer-to-peer program where if you would like to connect with somebody with a similar diagnosis as yours, or if you're a caregiver, we can connect you with a peer to speak with them no matter what your communication style. Or if you would like to be a mentor, we can help you connect with that. And we partner with Immerman Angels for that. And our other online support group is through Inspire. And I kind of describe it like social media for head and neck cancer survivors and patients and caregivers. And we have a policy that no post goes unanswered. So we have a lot of our ambassadors who are also wonderful people to connect with, that we can give you some of that connection that you may be seeking. So please reach out. Please remember, everything's on our website, but I'm here today personally. You can reach out to me as well. My name again is Melissa Cook, or any of our other staff members. We're happy to help.
All right, I think that wraps up the panel. Thank you to our panelists, Dr. Megami, Dr. Kaltman, Julia, and Beverly, and I think it's time for lunch.